Well, I'm a speech pathologist and I work with a craniofacial team here at our center. I have been involved with the Beckwith-Wiedemann syndrome population for about the last 8 years. What I do as a speech pathologist is I evaluate the child's speech, language, and feeding skills of many of these children, and I've seen children from birth up to the age of 18 years who are affected by this diagnosis and have been able to interact with them and their families. I first became acquainted with the Beckwith-Wiedemann syndrome, or BWS, population during my graduate training. At that time, I worked with a mentor who was seeing a lot of these children with this unique diagnosis, so I had the opportunity to begin interacting with them. At this point now, I've had the opportunity to become acquainted with a lot of families, be able to evaluate those children and interact with them as they grow up. At this point here, I've been able to evaluate almost 300 children with this diagnosis and gain more knowledge and experience about what really are their speech, language, and feeding concerns that are based on the amount of traits and associated factors that they bring to us. This is actually a very unique diagnosis that wasn't identified readily a couple years ago even, and now that there's more information available on the syndrome, it is becoming something more widely accepted and tested for in very young children. So we're seeing more babies and younger children being diagnosed very early, whereas they might find out that someone in their family maybe had a mild form of this syndrome, but it wasn't something identified 20, 30 years ago. So I was very lucky to fall into a position at a center and with a team who was involved with this population to begin with. I received training where I got to evaluate a lot of these children, and that really began my interest in the population, and I started my career having a good knowledge base about what to expect with this syndrome. In my experience in my career, I tend to specialize more in some unusual or very unique diagnoses, and we're one of the few centers who've had the privilege and honor to work with so many families from across the United States, all over the world, who come to our area for consultation, and we've been able to really hone in on what's expected when you first get this diagnosis. These children are born with a very large tongue. It's called macroglossia, and sometimes that's the first trait that a physician or a hospital or therapist might see, and therefore might prompt that physician to look into testing to find out, is BWS the cause of this, or is it part of the child's diagnosis. So feeding a Beckwith-Wiedemann baby might seem like a daunting task. You might see that large tongue and say, or assume, that this baby won't be able to feed very well. And in some cases there is some initial difficulty, but in most cases of the patients that I've seen, it actually goes much better than one might expect. Having a large tongue, or macroglossia, can affect the way that the baby will use their oral mechanism when they're taking a bottle. But it's important to look at all the child's skills and their developmental needs as a whole. Don't just look at that large tongue and give up. The difference between just a large tongue and having macroglossia, like in this syndrome population, is that the tongue is actually a very large tongue in relation to a normal-sized oral cavity. So the tongue often rests and works outside of the child's oral cavity because that's where it naturally wants to go. So many times breathing can be affected, feeding can be affected, sometimes speech can be affected. Again, when this baby is born and you see that the child has a very large tongue, one may assume that they're not going to be able to feed well, or they're going to have speech problems. As we've seen more and more children with this diagnosis, we have seen that just because the tongue is large does not mean this child isn't going to be able to be functional in their daily life. Some of the more serious problems that I've seen with feeding are typically related to other associated factors, those being prematurity or respiratory problems. Hypoglycemia is something that is associated with the syndrome, or gastrointestinal issues. And those factors appear to be more problematic as far as feeding and swallowing goes than just having a large tongue, macroglossia, on its own. And it's important to know that all those risk factors that I named, especially prematurity, those are problematic for any child. Those can be troublesome when you try to do normal feeding and swallowing right off the bat. But again, when you evaluate a child with BWS, you're not just evaluating the tongue, you're evaluating their developmental needs in general. Speech-language pathology is a pretty wide and varied field. There are many different areas that one with a speech pathology degree might work with. There are speech, articulation, language issues, feeding, swallowing, oral motor, many different things that they might do. I happen to be a therapist who has specialized in areas such as feeding and swallowing, also in the cleft palate and the craniofacial deformity population, and that's what really led me into the Beckwith-Wiedemann population, because they fell into a craniofacial diagnosis category. Because they have a large tongue and there might be some implications on their oral mechanism, I've been more involved with the feeding and swallowing aspect as well. As a speech pathologist and seeing a child very young, what I'm doing is you can't really evaluate the child's speech just yet if they're not babbling, if they're not talking in volumes like some of our older kiddos. But language development starts at a very young age. It starts at birth. And I can't evaluate a child's communicative skills. Even in a broad age range, I can find out if they're really, on target with the things that they do auditory comprehension, or with their expressive language. And we've found that many children fall into their normal limits. They fall into their normal age range, even very early before they're speaking to me. I can say that they have very good language skills. As far as the tongue size goes, with a very small child, I do evaluate how they feed. I can say that just because you have a large tongue does not mean that you're going to have problems, long-term feeding problems. However, a lot of times, I find this out from families who maybe come to me after their child has grown a little bit, and they say that there was some initial difficulty finding a bottle that worked out well for them, or finding some type of feeding method that their child was functional with. There's no one bottle that I can prescribe to a baby with BWS. I've seen some children who did just fine breastfeeding, and I've seen other children who've used a wide variety of different bottles or nipples, and they've done just fine as well. It's important to find a feeding therapist right after birth, or when you're having those troubles, to maybe help you find that feeding method that's going to be the best fit for your child. It's important to find a therapist who can find a safe and functional, efficient way for that child to feed. Some parents and families have had the opportunity to get that kind of support, and then I also hear from some families that they basically found something through trial and error, which may take a little bit longer and it may be more frustrating in the end. But just because you have that diagnosis of BWS does not automatically mean that you're going to have a feeding or a swallowing problem. With macroglossia, the oral structure is affected by having a large tongue, in that the tongue may rest outside the oral cavity or outside the lips, and wherever a tongue rests, that's where it wants to work as well. So many babies, when they first start up with their bottle feeding, you may notice that they might use that large tongue sort of like a bottom lip. It's more natural and more comfortable for them to use their bottom lip, to use their tongue as a bottom lip in order to get a seal around the nipple. So that's something that's very common, and it's amazing how these children can really find a way to compensate for that large tongue. What's happening is having macroglossia can affect the structure in a way that it interrupts what the brain automatically wants to do as far as feeding and swallowing. And babies will quickly pick up on how they can compensate and find a way to be functional. It depends on the child what bottle might be a good fit for them. And again, like I said before, there are other associated risk factors that may make a feeding or swallowing problem more significant. And those too have to be evaluated at a very young age so you can really address exactly what the child may need. We have seen that in some of our older children that I've evaluated that having macroglossia may affect the way that they are presented with solid foods when they get to the age where they might start spoon feeding. We do notice that some children have some initial difficulty, but when they're presented in an appropriate way, in a supportive manner, which I can do as a therapist. Some families find out a way to do that on their own, but a feeding therapist can provide a developmental food progression plan for that child, but a way to help that child be functional for the structure that they have. When a child is neurologically intact, all those skills are going to develop. Having a large tongue might get in the way of that development, and so you may have to make modifications on how you present a spoon when it's time for that, time to introduce those solid foods. Also, the having a large tongue may affect the way that the tongue moves in patterns that are needed for chewing or preparing the food orally before a child will swallow. Sometimes we hear that the baby might have significant trouble with softer chewable foods because they can't effectively chew them on their own. It could be because that tongue is getting in the way for them, and that's something that we can work with. Just because a child has a large tongue does not mean that they won't be able to eat and drink whatever they want as they grow older. It's just a matter of finding some supportive means for them to do that and to be a safe and to be an efficient feeder. Working with a plastic surgeon for a long time, we do know that tongue reduction surgery is not really something you do to correct a child's speech or to help with their feeding. That's not why you do the surgery, but we have seen that it definitely does help a child improve some of those patterns or really ease the effort that a child has to put into just everyday things like speaking, like eating what they want to eat and drink. With macroglossia in the BWS population, again, many people may see that tongue and assume that the child's going to have problems with speech. What I've found in seeing almost 300 children with large tongue now is that just because you have a large tongue does not automatically mean that you're going to have problems with articulation. Something that's extremely interesting is that many of these children can be 100% intelligible or understandable to a conversational partner, but what may get in the way is that there's a visual perception that there's a problem. Children with a large tongue may in fact compensate for that. Again, just like feeding, if the tongue is resting outside the oral cavity, it also wants to work outside the oral cavity. So many speech sounds might actually be produced in a different way. They might actually be produced with the tongue appearing outside the lips, and so that actually is a speech difference, not necessarily a disorder. It's something that's structurally based and not necessarily an articulation disorder that needs to be treated. Like the general population, speech therapy can be used for so many different things. A child may be seen by a speech therapist for articulation or for feeding or for apraxia or for pragmatic or social or language problems. And in the BWS population, it's essentially the same. Of all the children that I've seen, many of them are enrolled in speech therapy, but there's a wide variety of reasons or objectives why they have to see a therapist. Just because you have the diagnosis of BWS, it does not equal speech and language deficits. And if we see the child young enough, of course, that's something language-wise that you can evaluate very early and see if that child is doing everything receptively and expressively like you would expect them to develop. One of the most common effects of having BWS is having macroglossia. That's something that will affect a child's articulation, and we see that children develop phonemes, or they develop the sounds that they're supposed to be using in the right manner. However, they're using their tongue differently. Again, they're compensating for the tongue that's outside an oral cavity. If you weren't looking at the child acoustically, many of them will sound just fine. But when you're looking at them and there's that with the tongue being used differently than what you would expect, that sometimes gives the perception that there is a problem. So normal articulation or speech skills in language comes from the brain, not from anything else that you're looking at as far as the oral mechanism. When a child has a large tongue, it's basically affecting the oral cavity in a way that the brain doesn't expect it to. So when a child starts learning sounds and starts putting those into syllables and starts saying words, and you may see that they develop their sounds a little bit differently. They're producing sounds in a way that they're using their tongue functionally for themselves. And again, that's something that's really structurally based. And it's important for a speech pathologist to look at the child and evaluate them as a whole, evaluate exactly what their needs might be, not just to evaluate having a large tongue. We can't say that just having the diagnosis of BWS equals that you'll have speech or language deficits. We can say it puts you in a risk category for that, but you also have to look at all their other associated risk factors in their background that may affect their development as a whole. So me as a speech pathologist, it's important in my job to decide what is actually treatable and what may be something that's going to be functionally part of their lives. It's not because something happened to your brain and all of a sudden you lost the ability or capacity to make certain sounds. It's because there's something in the hardware that's kind of interrupting what the brain would naturally want to do. It's not that you've totally lost that skill set. It's an interruption in where the airflow is moving and how you're actually moving your tongue in relation to your teeth and your jaw. And children who are born with a large tongue never know any different. You know, they're developing their skills along with having a different oral cavity than the brain might expect. So many children find a way to be functional and they find a way to compensate for that. Children with more serious deficits in articulation or motor patterning or language may have some other causes that can affect that, but there are also patients just in the general population, children with no diagnoses at all who require speech therapy. So I do think that the prevalence in this population is very much like the general population to begin with. I've seen a wide age range of children who undergo tongue reduction as young as 2 months up to teen years, and I've been able to see them preoperatively and postoperatively. So we can't say that having a tongue reduction surgery will definitely cure all speech problems, and that's not the reason to do the surgery to begin with. But we have seen, and more children are old enough and at a speaking age where their language skills are developed enough to provide testing samples, where we can see that the tongue reduction surgeries actually alters a mechanism, and we find that children who maybe had production differences can change that or improve those patterns or eliminate the need to compensate with their tongue between their lips or outside the oral cavity. And it's neat to see how quickly a child can adapt to their new mechanism once the tongue reduction surgery is completed. But again, we do see some children who undergo the surgery and perhaps their speech and language is just the same after the surgery. You need to look at what is the root cause of their needs, their deficits to begin with. So again, the surgery alone, or speech alone is not the reason to complete that surgery, but we have seen that it can improve a child's articulation greatly, if for no other reason but visibly to appear more normal. And that really makes a difference to a listener and how they interpret what a child or a person is saying. I've seen some teenagers who Perfectly normal teenagers doing great in school, no developmental needs. They're 16, 17, and they put so much effort to keeping their tongue inside their mouth when they speak. And it's amazing what they just teach themselves to do, and they're very conscious of how they hold their tongue. And when those children have undergone a tongue reduction surgery, afterwards you can really tell that there's a new comfort level, there's a new confidence level that they may not have had before, because they don't have to put so much energy and effort into producing normal speech sounds like you and I do on a daily basis. Being a speech pathologist, it's very important that I help families find the resources that they are entitled to and help them get the references or the support that they might need. Having a diagnosis like BWS is a very unique diagnosis, and there may not be a large support network for that family. But it's very important when a child is born and diagnosed with BWS to get in touch with their local early intervention therapy services. Every state in the United States has their own funded program. It's usually an early intervention program, and they go by many different names. It's something that can be acquired by asking their pediatrician, for instance. But getting in touch with them will enroll their child into a possible array of therapy services, whatever that child may need, and they kind of serve as a monitoring service for them as well. So even if a child does not require regular therapy on a weekly basis for any need, whether it be feeding, whether it's speech, whether it's other like motor skills, physical therapy or something, early intervention services can come out and evaluate the child and decide if that's really necessary. It's important to monitor the child's skills as they grow and develop, especially between the birth to 3 years of life. That's a large, quick acquisition time, critical acquisition time for many different skills, and it's important that someone is evaluating how the child is developing. And it's really nice to get good news saying they're developing just fine. Why not have them come into your home and have them tell you that every so many months? So it's very important. I feel that not many families are discussed or given that option depending on where they are. But having a diagnosis like BWS, that's a craniofacial diagnosis, those children are entitled in many ways to be monitored and to make sure that their development is going smoothly, making sure everything is addressed as needed. Well, and there are many speech pathologists. There's 160,000 speech pathologists just in the United States that are accredited by our national agency. And not every speech pathologist works on every little thing. I don't work with many things that another speech pathologist may do on a daily basis. But because BWS is such a unique diagnosis, there really is not a lot of research or literature out there, much less a therapist or even a physician in some cases who is aware of the diagnosis and all the implications. So it's important to find those early intervention services where someone can evaluate the child for the skills that they have and look at what that child's developmental needs are. Not necessarily that they have a large tongue and I need to fix something, but to make sure that that child is staying on their developmental norms, because even a child with BWS, you can expect normal skills in many areas. That child can be a functional feeder, and they can have normal speech and language as well. It's important to keep on top of that and assess the child as they get older.